Hello, I'm Esther Oh. I'm an associate professor in the Division of Geriatric Medicine and Gerontology at the Johns Hopkins University School of Medicine. Today, I have the pleasure of discussing with you on the topic of non-pharmacological delirium prevention and management strategies. These are my financial disclosures. Many of us attending the ADS meeting already know that delirium impacts many older adults. It is estimated that over 2.6 million adults 65 years of age or older develop delirium each year in the US. And although many delirium prevention methods have been studied, multi-component, non-pharmacological delirium prevention methods have consistently shown to be effective in preventing delirium in a variety of care settings. And this is important because it is estimated that about 30 to 40% of delirium is preventable. And multi-component delirium prevention methods usually consist of the following approaches: reorienting the patient and providing activities, encouraging the patients to drink throughout the day, encourage early and safe mobilization, providing and reminding the patients to use walking aids, consulting a dietitian to provide adequate nutrition, make sure the dentures fit properly, and that there is someone available to assist during meal times. Asking the family to bring hearing aids and glasses from home. And if someone does not own hearing aids, providing a bedside pocket talker or other sound amplification device. Avoiding medical procedures and medication administration during sleeping hours. Turning off the TV and reducing hallway noise. Always look for and treat infection and limit catheterization. Assessing for pain and treating pain adequately, as overtreating pain may lead to delirium, but also undertreating pain can lead to delirium as well. Assess for poor oxygenation, and review and limit medications that may contribute to delirium. There was a systematic review examining the effectiveness of multi-component non-pharmacological delirium intervention by Shea et al. And there were 4 randomized or matched studies, which cumulatively showed 44% reduction in delirium incidence. Also, very importantly, multi-component non-pharmacological delirium prevention also reduced falls. There were 2 randomized or matched studies that overall reduced 64% of falls. It is also important to understand that these multi-component interventions can be tailored or modified for different care settings. Here's a study by Chan et al. Called Modified Hospital Elder Life Program, or mHELP. So this was a cluster randomized trial to reduce incident delirium in elective abdominal surgery. And this was a nursing-led intervention with 3 components: orienting communication, oral and nutritional assistance, early mobilization, and they showed reduction in delirium incidence. So delirium incidence was 6.6% in their intervention or the mHELP group, and delirium incidence was 15.1% in the control or usual care group, resulting in relative risk of 0.44 in the mHELP group. Although evidence for non-pharmacological treatment of delirium is not as strong as it is for prevention, still there are many studies that demonstrate benefit for non-pharmacological methods for delirium treatments as well. Next, I would like to discuss ICU Liberation Bundle A through F, which has also shown to reduce delirium and coma days in the ICU by 25 to 50%. A stands for assess, prevent, and manage pain. So one has to first assess the pain before treating. And you can assess patients' self-report of pain using 1 to 10 numerical rating scale, or use observable behavioral and physiological indicators for the assessment of pain. B stands for both spontaneous awakening trials and spontaneous breathing trials, where spontaneous awakening trials may involve stopping and titrating down narcotics and sedations as needed. But ultimately, both spontaneous awakening trials and spontaneous breathing trials would need to be coordinated together. C stands for choice of analgesia and sedation. Understanding the importance of the depth of sedation and choosing the right medication. For example, a non-benzodiazepine sedative option may be preferred over benzodiazepine-based sedative regimen. D stands for delirium. So assessing, preventing, and managing delirium. And of course, understanding of delirium risk factors and finding assessment tools for its assessment, and preventing and treatment is important. E stands for early mobilization. So early mobility has been associated with decrease in days of delirium. And it is important to emphasize that rehabilitation for critically ill patients should begin in the ICU, but ultimately continue during recovery at home. F stands for family. Involving the family in patient care can help the patient with the recovery process. You may wonder why we need a multi-component approach to prevention and treatment of delirium. Delirium is a very complex syndrome. So there's often an underlying vulnerable brain, but there are usually multiple insults or precipitating factors that can lead to delirium. I was taught that if you find one cause or etiology of delirium, the next thing to do is look for another cause. Bottom line is that care for older adults can be very complex and often needs a carefully planned, comprehensive plan. Although I discussed hospital-based approaches, including the ICU bundle, please keep in mind that multi-component, non-pharmacological methods of prevention and treatment of delirium can be used across different care settings. Thank you.